So I'm going to walk you guys through a knee exam tonight. Ideally, I've already watched him walk so I can get an idea for any antalgic gait, looking for genu valgus or varus at the knee, pes planus or pes cavus at the foot, or pes plano-valgus at the foot, just to give me an idea of any other abnormalities I should be looking for. First part of my exam is going to be an inspection exam. So just looking at his knee, we'll use his right knee for everything today. I would be doing everything with both knees if that was concerned for both knees, and also to be able to compare from one to the next. So what I'm first looking at is there discoloration? So is there redness or more concern for an infection? Is there an obvious ecchymosis? Is there swelling disrupting the architecture of the knee joint? What I would do after that is just feel it just to make sure if it is warm, are there any signs of infection? Big determinant in terms of what I would do right there. The next thing I'm going to have him do is just show me some active range of motion. And as I'm looking at his active range of motion, what I'm looking for is what is the track of the patella as he goes up and down? Is it straight or is it deviating laterally? So I'm going to have Tim just go up and down slowly for me a couple of times. Just watching where that patella goes and also what his range of motion is. He should have full range of motion with 180 degrees right there, or 0, or just slightly past full range of motion. Tough to tell flexion at this angle. I'll do it in just a moment. Next, I'm going to check for crepitus. What I want to do is exert pressure from the inferior portion of the patella superiorly to push it into the trochlear groove, and passively, I'm just going to extend his leg. And I'm feeling for it. You can also potentially hear it as the patella tracks through the trochlear groove right there. Next, based on this position he's in right now, we're going to check for muscle strength. So hip flexion, I'm going to have him lift up his knee like he's marching and hold it there, and push up against my hand. Once again, I would do everything on the other side to compare. Next, I'm going to check knee extension, so quadricep, push against my hand. Good. And then knee flexion for his hamstring, pull back. Good. One of my tests that I do at this angle as well is called the Steinman's test for meniscal pathology. I'm just grabbing his ankle. He's going to relax. Just doing a little bit of a twist out. Pain on the inside would be more concerning for medial meniscal pathology. And then this way, more concerning for lateral meniscal pathology. I'm going to have him lie down. The next portion of the exam is going to be while he's lying supine. I'm just going to put my knee underneath his knee just to get an idea for patellar apprehension. I'm just exerting a lateral force on the medial portion of the patella to see, does he feel like it's going to sublux or move excessively laterally, or does he have significant pain? This would be indicative of potentially risk of subluxation or other issues related to medial retinacular looseness. Okay. While he's also like this, as the knee is a little bit more so in the trochlear groove, I'm going to check patellar facet tenderness. So he's going to relax as best he can. I'm going to push his patella medially and palpate inferiorly underneath his patella and then along the superior portion. I'm looking for pain. Additionally, I'm going to palpate it and push it laterally and feel under the lateral inferior portion and lateral superior portion. These are signs that can be more indicative of patellofemoral pain syndrome, or if evidence on imaging, chondromalacia patella. I also want to make sure that, once again, I compare it to the other side, and next I want to make sure I get an idea of his passive flexion right here. So I'm going to lift up his leg, bring it all the way up to make sure I can get to about 130 to 150 degrees of flexion. I do like to do hip external and internal rotation to make sure I just have a general idea of what his range of motion is at that point. Next along here, I'm going to do some other more specific testing for the ligaments of the knee. I'm going to do the Lachman's test, which I'm just going to put my left hand underneath his distal thigh, my right hand right here, thumbs wrap around. My left hand is just for stabilization, and all I'm going to do is just pull his lower leg or his shin forward. I'm feeling for that snap or stop in movement, which would be indicative that his ACL is intact. Lack of an endpoint or a loose endpoint compared to the other side is indicative of an ACL injury. Once again, really important that they relax their muscles to allow for an accurate test right there. As I bring him up like this, I'm going to do the anterior posterior drawer test. Normally I would sit on his foot. For the lack of the reason of the camera, I'm not going to. I want to put pressure on here, keep his knee at about a 90-degree angle. I'm going to put my fingers right along the lateral portion of the patella. I'm going to pull it forward for anterior drawer, looking for more movement than the other side, and push it posteriorly for posterior drawer testing compared to the other side. More movement anteriorly is concerning for ACL pathology, but not as accurate as the Lachman. Posteriorly is concerning for PCL pathology. Next, I'm going to do meniscal testing with McMurray's test. So my fingers are going over the joint lines. I'm not pressing down hard. I'm asking him to tell me if he has pain over those spots. I'm feeling for clicking. He's also going to let me know if there's locking. What I want to do for medial meniscus is I externally rotate his foot. I bring him into flexion. I'm trying to catch the meniscus within the joint space right here. And what I want to do is bring him in, externally rotate his hip, and then extend him. And I'm feeling once again for clicking or locking as I do that. For lateral meniscus, I'm putting my fingers over the joint line once again, internally rotating his foot, bringing him into flexion, internally rotating his knee, trying to catch that meniscus within the joint line right there, and then extending his knee right there, just like that. One thing I forgot to mention to you guys right here was another test for patellofemoral pain syndrome. It's called Clark's test, where I have my knee right behind his leg right here. He's going to relax. I put a pressure just above the superior portion of the patella, and I asked him to flex his quadricep. What he would be doing is pushing through the back of his knee into the bed as I try to resist that. Pain with that motion, once again, would be indicative of patellofemoral pain syndrome right there. Okay? I'm going to have him go on his side just for one movement, looking for IT band syndrome. This is called Ober's test, O-B-E-R. He's going to flex his leg that's on the bed all the way up to his chest right there. He's going to allow me to grab this leg. I'm going to go to the other side. What I want to do is I want to make sure I abduct and extend his leg while he stays on his side. And what I'm going to let it do is just drop. What I want to make sure is that it goes to the level of the bed, if not lower. You can also do this off the side of the bed. If it's tight and stays up here, that's indicative of IT band tightness or IT band syndrome. You can sit up to him. The last thing I wanted to show, which I commonly do, is what's called a one-legged squat. I'm just going to do it for sake of time right here. What I'm looking for is weakness or inbending of the knee, which could be weakness of the quadricep or hip abductors or gluteus muscles. What I explain to patients is I want to make sure they keep their knee directly above their foot and try to go down as best they can. If they're going down like this, certainly signs of some muscle weakness.